my college roommate as well. Anyway, she was working with Greensboro News and Record, and I was visiting her. And it was a downtown festival. We went to the bank to get something to eat, to get some money so we could eat. And I met Keith at the bank in Greensboro, and we just, we kind of connected, exchanged numbers, and then we ended up being married, and he was in graduate school at A&T, State University in Greensboro, and I was and then I ended up in graduate school down at Emory University.
So you weren't married yet, but your relationship began long distance.
Yes, and then we ended up getting married, and so for the first year of our marriage, he was in Greensboro and I was in Atlanta.
Oh goodness. Okay.
Oh yeah, it was great. Kept things interesting for sure.
You did your studies. And then you had fun.
That's exactly right. So we would meet up halfway in South Carolina. What was that? I can't remember. Columbia? I can't remember, but it was somewhere in South Carolina we meet. So it was fun. Yeah, we made it fun. Yeah.
So any thoughts about Emory that you want to mention? Your experience there? How did it compare with UNC?
It was different. It was definitely very different. I felt like by the time I got to that program, I really just needed to get done, and so that I could go on with the next phase of my life. I did have a chance to work with Dr. Henry Kahn. He was one of the professors in the program, and he was very much interested in just some of the community outreach. So I had a chance to do some work with him.
And you were a research coordinator.
I was a research coordinator with him, yeah. So that was an interesting experience, but it was just really different. That's all I can say. Yeah. But it was good.
Did you feel it was more welcoming for diverse African American and other students there than UNC, or less, or is that something you didn't think about much then?
I think by that time I was cool. I was really good. I was fine, but I can definitely say the focus on diversity I felt was more prominent at UNC. I can definitely say that. But at Emory, it was we just went through it and we just did it. Yeah.
Okay, so then you came back to North Carolina, thankfully.
Thank you.
Love
will make you do things. That's what I tell people. So that's how I ended up back in North Carolina. No regrets, certainly. But I came back after a year of a long distance marriage, and just wanted to figure out, what to do. And so I started with the American Cancer Society in Greensboro.
Mm-hmm.
Did that work. That was good work. It was tough work in that I really felt like I was opening the door for the American Cancer Society into many African American communities. So I worked in about 6 counties, and I mentioned like Lee County was one of my main counties, but I also worked in some of the northern counties in North Carolina, and it was tough because trying to open the door when at that time the black community was still calling cancer the C word. Didn't want to deal with, didn't really want to talk about it, and it was a tough thing. And of course the outcomes were not as favorable as they are now, So I understood all that, but it was an interesting job because I had multiple hats. I was educating the community about cancer, but I also had a fundraising role as well. Boy, now the fundraising was quite interesting. We did jail-a-thons.
What is it? Jail-a-thons.
Jail-a-thons in Sanford and Lee County, for example. That was a big deal and a big fundraiser, in which we would have we'd have it set up like at I know the Ford car dealership was one of the places for the jail-a-thon in Sanford, Lee County. And we would have some of the prominent leaders would be literally in jail at the Ford dealership. We'd have a little setup, like a little staged jail, and people would come through to give donations just to help them raise money so they could get out of jail. And so it was fun. It
Now,
was
this
a lot
wasn't
of
just for the
music.
black community, was it?
No, this was for everybody. So that was pretty cool. And the other fundraiser that we did in Sanford, for example, was the golf tournaments. Now the golf was fun because the only thing I did was to drive the carts. Never played, didn't even try, but it was fun. So we would laugh and have a good time out there on the golf course. And to this day, I'm still just pretty good at putt-putt. That's about it.
Can you still drive a golf cart?
I can still do that. Oh yeah, yep. I was good at that.
So then you transitioned from Greensboro to Raleigh.
Yes, and so working with the American Cancer Society, and I actually was recruited to come in for an interview for the a new program that had just been passed by the General Assembly, and it was the Adolescent Pregnancy and Prematurity Prevention Project. That's a mouthful. And in that role, actually worked again to build and organize communities around a very tough issue, very controversial issue. I think controversy has always followed me in my career, which is really interesting. But with that, it was good because I worked in about 33 counties, so it really covered about a third of the state. I was young, I had energy, right? And so we would go and help to build coalitions and organize communities around an issue and around teen pregnancy prevention.
This was the mid-'80s, right? 1985?
Yeah, it sure was. It sure was. So, I was the first coordinator, first consultant for that program. Mm-hmm.
Wow. Well, I'm trying to remember what was going on then in the legislature and so on. Was that when they said no sex education without public hearings, or was that later?
I can't even remember the time, and it may have been a little later though. Yeah. But yeah, that was a tough one because it was a subject that people didn't want to talk about but needed to talk about. So just trying to open some doors.
And how did you get recruited to the program? Because this was now in the state,
yeah,
the state health department.
Well, I'm not sure.
It was called.
I'm not sure how Phyllis Gray, who was working in the Division of Public Health, and I think she was a special assistant or something to the state health director at that time, Dr. Ron Levine, of course, Dr. Ron Levine. And so she called me to come in for an interview. I did the interview with a team initially. Then I did a second interview with Chris Hoke, who was Dr. Levine's deputy director. And then I was offered the position. Dr. Levine called to offer me the position because I did another interview with him. Yeah. So we went through that process and had great support from Dr. Levine to do that work for sure. And it was tough.
Let's see. So then I guess you did some other things with adult health promotion and some other things with the state, but then came the Office of Minority Health. I guess it wasn't even called Health Disparities, then it was just the Office of Minority Health.
It was actually just the Office of Minority Health. And
where did that come from?
Oh yeah, I love the story about how, because it's a perfect example of how when you look at the data and use the data to make policy decisions, you can really have a tremendous impact. So I guess the Margaret Heckler report was out, and so the nation was certainly buzzing about there's something going on with the differences, in terms of minority health. And Delton Atkinson was a staff person at the North Carolina State Center for Health Statistics. And so he did, he looked at the national data and said, I wonder what the picture looks like for North Carolina. And he actually developed the first and published the first, I think it's called the Health of Minorities in North Carolina in 1987. And he did that report without the blessings of his supervisor. So he really took a risk.
Wow.
He really did take a risk to do it, but it was because of his leadership that it really forced North Carolina to take a look at this issue. And so it got in the hands of Dr. Levine. And of course, Dr. Levine said, we need to put together, I think he called it like an advisory council or something. And so there was a committee, it was an advisory committee. The committee got together and they recommended two main follow-up actions. One was to establish the Minority Health Advisory Council, but also to establish an Office of Minority Health for the state of North Carolina. And so that's how the conversation started in about 80, I guess by that time it was about 88 or 90. And so the approach was that we needed to get legislative approval for it because we needed to identify some funds to get it started.
So what was the workforce in the State Health Department like in those years, say around 1988, 89, 90? You're an African-American member of the staff. Were there many other African-American members of the staff? Or?
No. I was one of the few black females on the management team, but she was at the state health director level. Mm-hmm. I was at the division level at that time, and no, there were not that many African American staff persons. Yeah, not in terms of program managers and mm-hmm. people in leadership now. Mm-hmm. Yeah.
So the office was created in 93.
In 93.
And you were the first?
No, it was actually created in 92.
92, okay.
Right, but the legislation passed in 92, and I became the founding director in 1993.
And how did that happen? I mean, were you working for it? Were you expecting to be selected? That's quite
no, I mean, it's interesting because it's interesting how just a conversation with one of the people who actually was a leader with the Minority Health Advisory Committee that Dr. Levine established. Leslie Brown, who's an mm-hmm. attorney, mm-hmm. was working in public health, and he had a leadership role in public health. He was one of the few black males to have a leadership role in public health, and so he was on that committee. And he's the one that he and Phyllis Gray encouraged me to apply for this position. So Phyllis Gray has truly kind of guided me. She helped to shepherd me. She absolutely did. And I thanked her for it many times. And then some days I'm like, Phyllis, what have we gotten into? But so Leslie Brown and Phyllis Gray actually were the ones to encourage me to apply for the position as director of the Office of Minority Health.
Now, I can't remember if this was the task force or the council that Charles Blackman was on. Do you know Charles Blackman, who was with the North Carolina Mutual Life Insurance Company?
I do remember Charles Blackman.
But maybe he was on something that started later.
I know that I did some work with him. He was on the council. He was on our council, and we also did some work around smoking cessation too. Yeah, he was mm-hmm. very much engaged with that. Mm-hmm.
So what was it like creating and running the Office of Minority Health, and then it became Office of Minority Health and Health Disparities?
It was my greatest adventure because I loved being the founding director because I didn't have to figure out how to continue something. Everything was from scratch. I mean, literally, when I was hired, I remember Phyllis Gray. I mean, there's Phyllis again, shepherding. She came into my office, and she brought me a box of some materials that she'd gathered from other, because by that time there were a few other state offices of minority health around the country, Ohio being one that was like the mother. Now we always looked at that one as our model to build around, but she came in with a box, and so I just remember starting by bringing together just some of the smart people in public health from the university setting, I remember some people from UNC Chapel Hill coming, and we did a strategic plan for the office, and Phyllis helped me to organize that, and that document literally helped to lay out the vision. That was like a 10-year, maybe 5-year strategic plan, probably 5-year strategic plan, but it really helped to set the path and the course for where we could go, and some things that we could perhaps have some influence around with the state. And so one of the things that I wanted to make sure we continue to do is to tell our story, and tell our story meaning the stories of racial and ethnic minorities. And so we actually started the first minority health fact sheets, in which we had, because before they were doing a minority health fact sheet, I said, no, I think that we need to make sure each population sees themselves in the data. So we did one for African Americans, and we did one for American Indians, and we did one for Hispanic Latinos in the state. And so those tools were really helpful, so that we went to those communities to say, this is the data, this is the way, this is the health impacts for you. It's not, so we're going to focus on how do we address these concerns based on the data for you. And that really helped a whole lot.
Was there one for Asian Americans and Pacific Islanders?
We did not do a report. We did not do a fact sheet for that population, and I can't even tell you why we didn't. I can say though, when we decided to take the data and break it down a little, to make it a little clearer, a little more plain, a little more in your face, so that, and that was really so that we could have a document that policymakers really could look at a glance and understand the problems in terms of health disparities in North Carolina. And so it was in 2003 we did the first health disparities report card. And so we updated every 3-4 years. And that report card looked at not only the chronic diseases and conditions, but it also looked at issues of access to care as well, because we used BRFIS, the Behavioral Risk Factor Surveillance System data, to look at just some of those variables too, and included, and we had a team of people, epidemiologists and folks from the State Center for Health Statistics, to figure out a grading scale, and looked at disparity ratios. And so it was quite a telling document. And I loved it because you can refute a lot of things, but you can't refute the data. You can tell me what you think, but the data spoke for itself. And so we would tell the story simply by opening up the report card and saying, I don't think that it's acceptable for North Carolina to be failing when it comes to HIV/AIDS and African Americans. It's not acceptable. And so that's how we use that data to really drive home that if there's not an investment in the communities in a different way, It is not to say that the health departments weren't doing their job. It was not enough. And so we used that data literally to influence legislation to create one of the signature programs, I think, for our office, which was our community-focused Eliminating Health Disparities initiative, in which we funded community-based projects.
And when was that? Was that after 2003?
It was after 2003. I was trying to remember when we actually first started it, but yeah, it was well after 2003, because it took a while to get the legislation passed. But what we were able to do with the community-focused Eliminating Health Disparities initiative is to include in the legislation that the funding would go to faith-based organizations and American Indian tribes, along with local health departments. And so I think and people were shocked at how we were able to slide that in there, but it was very intentional. Because the past had been that maybe there were some community resources, but it was really competitive and tough for faith-based organizations and American Indian tribes to compete against some of the bigger organizations and the organizations that had a longer history in the state and perhaps more resources. So that really that just kind of leveled the playing field a little bit. So that was some of the best investment, I think, of state dollars. I definitely believe that, because we invested in building up people and helping nonprofits really develop. And so we were able to put money in put some resources in the community. Not only did we give them money, but we also gave them support and training, board development, helping them with setting up their organizations and making sure there was good organizational management in terms of managing their funds and being audit ready and all of those things, because the capacity is what was lacking. They had the heart to do the work. And I think the thing that really pushed me to really try to get the office and some resources out there was because what I saw was, while the health departments were getting money to serve everybody, the disparities were still there. Like I said, you can refute a lot of things, but you can't refute the data. The disparities were still there. And so I said, well, and I got a lot of pushback. I got a lot of people really who were against that whole approach, because they were like, health directors, oh, well, Barbara, we have capacity. You're trying to build capacity in the community. I said, well, obviously, you've had the money for years, and certainly have the responsibility. I'm not trying to take that away. I'm saying that we need to invest in people and use a different approach, because obviously something's not working. Let's give this a try. Let's just give it a try. Let's just do something different. And so that's how we invested in people. Some of the best work we did was that initiative, and the other one that really was about lifting up communities was our Community Health Ambassador Program. And that was based on the Lay Health Advisor model, so I got to put that back into practice too. And the focus was on diabetes.
Were you able to show any difference in the data after the new programs?
Not statewide, but certainly we saw some positive improvements. But as you know, that it takes a lot. It takes a whole lot of time, and it would have to be a much bigger effort and a bigger investment in order to change the data at the county level, which is pretty much what the state center was documenting. But in terms of just some changes within the populations and the way they tracked, absolutely.
And at the national level, we've had these strategic plans, and then when they, the goals for the nation and so on, and then when they evaluated 5-8 years later, the disparities are still there.
Absolutely.
So
it means there's still a lot of work to do.
It requires really fundamental changes.
It does, but I definitely will always invest in people. I will always think that that's the best way. Invest in the people who are experiencing the disparities and teaching them how to fish.
Well, fundamentally, it has to be investing in those people, because otherwise they'll always be disadvantaged.
And we have enough history to prove that, so
Yeah.
I don't know what else it's gonna take, right?
Plenty.
Don't know what else it's gonna take.
You mentioned the strategic plan, and there was obviously many, many other documents, and I just wondered, are those documents accessible, available, preserved somewhere?
I probably have some of them, and some of them are probably still in the Office of Minority Health, but yeah, I probably have
I mean,
some
if
of those
somebody
things.
listens to this interview and wants to actually study this, write about it, where would they go to find it?
Oh my goodness. I would start with the Office of Minority Health because certainly some of those records are still there. And then I also have some of that. I just,
What will you do with your documents when you're ready to dispose of them?
I don't know.
Is there a state archive for documents, or?
I don't know that they would include these in
We
the
might
state
talk
archives.
to UNC
Yeah.
then,
Oh, sure.
or
Oh,
do
sure.
just to be open,
Oh, sure.
open access.
Oh, sure.
I've been
But I'd love to
talking
do
with
that.
archivists at the UNC now, and I'm
Yeah.
getting more aware of the importance of preserving documents like that.
Oh, that'd be awesome. I'd love to share that too. Yeah.
I
Absolutely.
was going to ask you also about collaborators. Did you have particular collaborators during this period of time that you worked with, either individuals or organizations?
I would say that we were successful as an office to build some long-term relationships with a lot of faith-based leaders. So we implemented an initiative with faith-based leaders around, it was called the Community Empowerment Network. And we started with Dr. Calvin Ellison out of Farmville, North Carolina. And that network involved faith leaders from around the state. I think we had about 20 or so different counties involved and leaders from those counties. And then we did a lot of work with the American Indian tribes with that organization because, again, we were trying to reach population. We worked with the Hmong community. Yeah, we definitely had a lot of collaborators, and they were people, a lot of the collaborators were people out there trying to deal with the issues that they understood for their community. So yeah, that was pretty awesome. So it was very diverse. I loved it. And with the Latino community, we did work with the consulate. I mean, we did a lot of work with nonprofits from across those different populations.
And what about, you mentioned there were some people from UNC who helped you create the office, or not maybe create it, but guided it. Any names that stand out in your memory? Without preparation, that's a little hard to do, but I just thought
Yeah, I was actually trying to remember some of the people now, because I do remember Dr. Hatch being in on some of those conversations. Jeannie Ng, of course, was also in on some of those conversations. I was trying to remember who else from UNC. No one else is coming to mind right
okay.
now.
You can add that later maybe.
Yeah.
Now, I don't know how much you want to talk about opposition or things like that, but besides collaboration, there's also are there any things that you wanted to mention in that regard?
Some of the things that we had to work through, and Dr. Levine was absolutely, I think, he was phenomenal in terms of being a leader around issues of language, disparities, and access, especially for the Spanish-speaking population. And so I can't remember, it was in the early years, 95, something like that. It's when we had an influx of the Spanish-speaking population, and a lot of it had to do with just the work for the workforce, but in rural North Carolina. But it created, oh my goodness, all kinds of challenges for local public health agencies. And so we had to work through the perspective, that opinion of, well, if they're in America, they should speak English. To helping them to see that the health problems, the communicable diseases, all the issues that we're concerned about in public health cuts across language barriers. It doesn't matter. So, and so we had to involve Jane Perkins with the law. She was with the Law Center, but she did a lot of training with the health directors around just the rights, the people's rights, to have access to the health information in their language. So we went through a whole lot of initiatives. Mm-hmm. We did a cultural diversity training initiative, which was another one of our signature projects, in which we trained a lot of the public health staff on understanding the value of appreciating other cultures and how everybody can't fit into your box, but the people who come into your system need the services you provide. So let's figure out how those services can be a little more welcoming and address issues of cultural differences, so that every brochure can't look like the same, because it's not going to connect to different populations, and just some basic things like that. So we did cultural diversity training initiatives, and that was really we did that at the local level in terms of with local health departments, but we also did it at the department level as well.
The state level. At
the State Department of Health and Human Services as well, because yes, we really wanted to make sure that all the departments, across departments, whether it was social services or public health or mental health, that they understood that there were disparities in services, or help them to define what they were, and for them to look at how they can change policies and direct resources. So
now the Office of Minority Health was a little bit of a different organization than the other parts of the state health, which was Health and Human Services. Mm-hmm. And I wonder, how much did the other departments become more diverse along the way? Did you see that happening, and how much did they kind of adopt these goals for their offices as well?
Well, I can tell you, we had a nice run of having that level of influence at the department level, and working across 14 different divisions within the Department of Health and Human Services under the leadership of Secretary Carmen Hooker Odom. And so that's when I was reporting directly to her. And so it elevated the work of the office, but it also elevated the issue of health equity and health disparities. And so it was at that time we had cultural diversity training, we had the different divisions actually developing their own health disparities elimination plan for their services. So yeah, we definitely saw some of that. And of course, a big part of what we always focused on was the importance of diversifying the workforce. Mm-hmm. And I always tried to make sure that the Office of Minority Health represented and led that effort by having diverse staff,